5, 4, 3, 2.
Welcome to Westchester Jewish Community Services. As a leading agency in providing a comprehensive spectrum of human services, we have been helping people since 1943. We serve all people in Westchester County, regardless of age, income, or ethnicity. We provide a wide variety of essential and dynamic services that make a difference in people's lives. Children, teens, adults, and senior citizens are served by our network of programs located throughout the county. When people come to us for assistance, they become part of the WJCS family. Our highly trained and skilled staff focus on you and your family and are committed to becoming your partner in finding solutions. For more than half a century, we have been connecting people to services that help them overcome mental, physical, or emotional challenges. WJCS is here in your community when you need us.
Welcome to The Ways We Care, a program brought to you by Westchester Jewish Community Services. We are in your community when you need us. We are funded by government grants, corporations, UJA Federation, private individuals, and the United Way. I'm Merrill Lewis, and I am the Corporate Outreach and Volunteer Coordinator of WJCS, as well as a former director of the OC Foundation, the national organization, which is located in Connecticut. You find you must check your stove many times and are never satisfied that it's turned off. Your child begins to fear germs and washes hands until they are red, chapped, and bleeding. You can't bear to throw anything away, and you're saving junk like gum wrappers and old tissues. Are these eccentricities, or are they symptoms of a fairly common illness called Obsessive Compulsive disorder? Recently, OCD has come to light in movies such as Good as It Gets with Jack Nicholson, and the new movie American Splendor, whose main character is a hoarder. The TV program Monk features a detective who uses his OCD to his advantage in solving crimes. Today, we are going to discuss OCD within the family, coping with OCD when a family member is suffering from it. I have two very distinguished guests today. I have Dr. Andrew Levin, medical director of the clinic, the WJCS clinics. And I also have Scott Greisberg, who is a psychologist who specializes in OCD, and he's with the Institute for Cognitive Behavioral Therapy Research in Ardsley, New York. Thank you both for coming.
Thank you.
And I'd like to address my first question to Scott. What are the symptoms of OCD? How would you know a family member is exhibiting symptoms of OCD?
Well, interestingly, sometimes it can be hard to tell, actually. Very often people will try to hide the symptoms to some extent or be embarrassed, but the primary features would be the presence of obsessions and or compulsions.
What can you describe what an obsession, a few of the typical obsessions would be for us?
Well, obsessions generally fall into several categories that we commonly see. They can actually be an explicit thought, a worry, so to speak. Very often topics will include worries about being contaminated by something, becoming ill, some danger to the self or others, either through an action that the person might do or not do. They can also be somewhat less commonly seen. Types of obsessions might include sexual content, violent content. Interestingly, they're not always worry thoughts per se. Sometimes they're just an image, maybe even a sound, something. Really, an obsession is essentially any unwanted, distressing thought that repeats despite efforts to not have the thought.
Dr. Levin, do we know what causes OCD?
We believe that OCD is caused by changes in brain function. We know that it has strong genetic roots, meaning people who have parents who have the disorder are more likely to have it than others who do not have affected parents. So there's definitely an inherited component. We believe that there's dysfunction in specific areas of frontal lobes and also some of the other parts of the brain that regulate repetitive movements and repetitive thoughts.
So basically, you are born with OCD?
Like all these conditions, one is born with the vulnerability, although OCD seems to be the kind of condition that makes itself seen very early. It's often commonly seen in children. Children normally have some obsessional thoughts and behaviors, but for the OC child, these really continue and become very intense and interfere with their functioning.
Well, for example, what would be a trigger? If you have the predisposition, what might be a trigger where the OCD would come out?
Well, I think in general, we don't know the triggers for the majority of cases. Clearly, stress is something that we know triggers many different kinds of mental conditions, and we assume that that probably plays a role here. There are a small number of children who may develop OCD after an infection due to an effect of antibodies. But this is really a minority, and I would say in general we don't know the exact trigger for the onset.
Scott, I'll address this question to you. How common is OCD in adults and children? And do people who have OCD as an adult, have they started as children?
You know, that's actually that's a great question. I'll say the short version is we don't quite know 100%, but we have some evidence to indicate answers to those questions. The first half, you asked about prevalence, how frequent does this condition occur. The published estimates range from lower estimates at around 1% up to some of the higher published estimates can be 3, 4, and even 5% in some samples. That's to say diagnosable levels that where people make it in to receive that diagnosis, make it into some evaluating professional. We suspect that there's a large number of people who never find out that they have OCD or don't make it in, don't know that there is treatment available. So the actual numbers are probably larger than that. And the second part of your question about adults versus children, there are sort of two schools of thought on that. Some theorists pose that there's what we call a bimodal age of onset, in that there's a large group that would have onset in childhood, and that might be a distinct type, and then some who would have it onset as adults. Although some more recent studies have suggested that up to 80% of adult cases can trace roots back to childhood. This kind of research becomes somewhat difficult, though, because it requires adults to try to remember when it started, which can be tough.
Dr. Levin, can you outgrow OCD?
I think it's probably better to think of it as a fluctuating condition that does not go away. In adults, sometimes we see a situation where an adult may develop a depression or some other kinds of mental symptoms and then develop what looks like obsessive compulsive disorder, but when the depression recedes, then those symptoms also go away. We also see OCD symptoms at times in schizophrenia, although again, when the schizophrenia improves with treatment, the OCD symptoms go away. But for people whose primary condition is OCD, whether it starts in childhood and continues or really makes itself prominent in young adulthood or during adult life, those folks don't outgrow it, but they may have periods when they're better and other periods when they're worse.
So it waxes and wanes depending on stress levels?
Probably. We are not certain about this, about what makes it wax and wane, but we know that most mental conditions wax and wane and are not uniform and are stress, have an interaction with stress.
Well, here's another question. How would you know, for viewing public, how would you know if you or a loved one has OCD and if it's severe enough to warrant professional attention?
Well, I think as Scott was saying, OCD really contains two elements. One element is the thoughts, recurrent thoughts that people can't get out of their heads, and they may be thoughts about contamination, but they may also be odd or strange thoughts. And people who are suffering will say things like, I can't get these thoughts out of my head, I know they're crazy. And then the second half of the disorder is some behavior to try to compensate. So if you're afraid of contamination, you may wash frequently. If you are afraid of that you killed somebody on the highway, a strange thought indeed, but people have it, then you may go paging through the newspaper for hours. So when somebody has thoughts that intrude, that are odd, and they can't get rid of them, and they make them uncomfortable, and they do behaviors to compensate, especially enough to interfere with their functioning. They can't get out the door because they're spending so much time washing. They can't get to school because they have to look at themselves in the mirror 50 times or 100 times. I have a patient right now in my practice like this. Then they know that they have not only obsessions and compulsions, but it's interfering and they need help.
What do you do with patients who exhibit only obsessional thoughts but no compulsions? So where a patient might have perhaps horrendous thoughts. First of all, how do you find out he is having these thoughts if he won't share them with you? And then what do you do with them once you know he has these thoughts?
Interesting, yeah. The treatment that I employ for OCD symptoms is cognitive behavioral therapy. Specifically, the principal, most important ingredient in that treatment is what we call exposure. In the interest of time, I won't get too detailed in a description of that exposure at this point, but the question of what to do with a client who only displays obsessions, the first question would be, are there indeed only obsessions, or are there hidden, not obvious mental rituals? What I mean by that is perhaps the behavior that attenuates the anxiety might be some mental action that the client takes. Regardless, the goal would be to expose the client to the fear-inducing event, be it a thought or something in the environment.
Can you give us a specific on that, a specific example
Sure.
of exposure?
For the sake of simplicity, I'll pick the classic thing that most people think of with OCD, contamination. And certainly something we see frequently in practice. And I'll think of a client that I've treated. This client had a fear that if he was to touch publicly used things such as doorknobs, tables, pens that might be available to the public, that there would be a transfer of germs resulting in an illness. So the exposure would take the form of basically doing the opposite of what the OCD, the disorder itself, encourages the client to do. The OCD would suggest that the client should avoid contact with these items completely. And when that's not possible, to go to great lengths to ensure that all contamination was removed, washing, antibacterial agents, things of that sort. So the exposure, the cognitive behavioral treatment, would involve a gradual exposure to successively more difficult and fearful stimuli. So we might start with touching a pen that only I, the therapist, had touched, that the client might have seen me take it out of the box, and gradually work our way up in a hierarchical fashion until eventually the client has become quite skilled at touching things that were originally very difficult.
So now this is done within the session. Are the clients given homework to try to carry this out throughout the week?
That's a great question. Indeed, the treatment is a lot of work. I think that clients should go ahead with the treatment when they're ready and committed to do some difficult work to get rid of this condition. I often equate it to getting a new personal trainer. As the therapist, I provide exercises that you can do that may be challenging at times, but will, in the long run, obtain serious benefit. My job, though, is to be a good personal trainer, quote unquote, and come up with exercises that are fair and doable.
Well, it sounds like it would be very, very difficult for a person with OCD to do some of these exercises and homework assignments. I just wonder if medication might help, and what kinds of medications are given to whether they be children or adults with OCD.
It's been a couple decades now, at least since the 70s, that it's been observed that medications that affect serotonin, and many of these are also called antidepressants because they affect mood, these groups of medications are very effective for OCD. The first of these medicines is one that is still in use, but most people don't know about. It's called clomipramine. It's a cousin of a medication called tofranil, or imipramine, which people have probably heard of or may have heard of. And that was a medication that was used primarily for mood in the 60s and 70s. And it was developed in the 60s. And its cousin, clomipramine, which has a lot of effect on serotonin, was found to be very effective in relieving symptoms. And when I say very effective, usually medication relieves symptoms in the probably 70 to 80% range. And we might measure them by measuring how much time someone was spending checking or how much time they were spending thinking about the worrisome thoughts. So medication can take people quite a ways. Now, we have newer medications, which are really all the medications in the selective serotonin reuptake inhibitor. That's kind of a mouthful.
Is that English?
That's a mouthful. Most people are more familiar with Prozac, or fluoxetine is its chemical name. And Prozac is one of a family of medications that all affect serotonin and that we know are helpful for low mood, but they also are very helpful when used properly in OCD.
Can you backtrack a little bit and explain serotonin reuptake inhibitor and actually what that means?
I can. Serotonin
in layman's terms
is one of a number of chemicals in the brain that we call neurotransmitters, and these are chemicals that carry signals between brain cells. People have heard of serotonin or epinephrine, or there are dozens of these substances, but those are the ones that people have probably heard of the most. These medications increase the activity of serotonin. They help serotonin carry the message for a longer period of time, meaning a few milliseconds longer. And that affects firing patterns, which somehow rebalances the system and causes a decrease in these symptoms.
And how long must a person, first of all, how long does it take for these medications to kick in and begin working? And then how long does a person stay on the medication?
Well, the first answer to your first question is that these medications, when used for depression, for low mood, can show noticeable effect in a few weeks or even 1 or 2 months. But OCD is really a different kind of situation, and it's long been observed that people need to stay on these medications for at least 2, 3, maybe even 4 months at high doses, often higher than they might normally need for a mood problem, before they get the full response in terms of OCD. So the strategy is to start someone on a medication, start them slowly and gradually increase them, and make sure that they're not being bothered too much by side effects. And then give it time, and hopefully after 3 or 4 months, the person will achieve a good effect, will have a significant decrease in the symptoms. And then the usual recommendation is to keep them on the medication for at least 6 to 12 months. But since we said before that this is a chronic condition, the field has gradually moved towards keeping medication as part of the picture for many months or even years, just the way you would in heart disease or diabetes or any other chronic medical condition.
Really? So it's really not much different than managing diabetes, for example, where you would take insulin.
Oh, well, I think that the diabetes analogy is a good one because taking insulin helps part of the problem in diabetes, but there's also a management issue, eating properly,
diet,
exercising, and I think this is very true in OCD, that medication alone is not the solution for the very large majority of people. There are a few people who find that medication alone really makes a big difference and they don't need much else. But usually they need a combination of that kind of treatment and the kind of exposure treatment that Scott is describing.
So that both would be the treatment that works best, both in combination with each other.
This is the current recommendation, is for people to receive both kinds of treatment.
Now, what about side effects to the medications? What kinds of side effects can a patient typically expect?
Well, of course, we're talking about really more than half a dozen different medications to choose from, so we have to talk in generalities. The good news is that people often have rather minimal side effects to the Prozac family of drugs, although I can see that our audience, the people be jumping up and down saying, well, wait a minute, that's not true.
Right.
And of course, that is not the case for everyone.
Right.
So there's some people who have minimal side effects. Other people who experience with these serotonin drugs things like headaches and stomach aches, sometimes fatigue, but those things often go away if you stick to the medication and start at a low dose and are careful. And then there's a vexing side effect that a significant number of people get, which is some decrease in their sexual interest or function. This is not invariable. Some studies say it's a quarter, some studies say it's a third. It varies tremendously. And there are, at times, ways to solve that problem. So, like any medication, you have to assess its benefits and then assess the disadvantages of it and try to balance them, change the dose, maybe try another related medicine. So it's a strategy just like managing a medical condition.
Really, so consumers should actually make sure that they look for someone who's very familiar, a psychiatrist, to manage these these drugs very carefully, to make combinations of drugs. I would think. What would you say to a parent who says, I don't want to put my kid on a medication forever. You know, what's it going to do to his growth, or how is it going to affect him 15 years from now?
I think if you're talking about a child, meaning a pre-adolescent or a small child, a school-age child, certainly a try with the exposure and behavioral treatment is called for in the beginning, and often that is helpful for children and can be quite helpful. And again, the choice to use medication has to be part of a bigger picture. How severely impaired is the child or adolescent? What are we trying to balance here? If you have a situation where a child or an adolescent is unable to go to school, can't touch other people, is so isolated that they're not functioning, and I have someone in my practice who had suffered at this level, then medication becomes an important consideration, because otherwise the person is not functioning at all.
No quality of life.
That's right.
Yeah. I guess that would be the deciding factor. Take your chances for a better quality of life. Scott.
I just
Sure.
would also say that the good news is that these are medications that have been very widely tested. We don't believe that there are any long-term negative effects for the Prozac family of drugs in terms of growth and in terms of long-term effects on people's thinking or behavior.
Addiction? What about addiction?
These medications do not cause addiction.
Okay.
As addiction is where people take increasing doses of a medication or a drug to get the same high and neglect other life function. And in fact, the purpose of taking medication is the opposite, which is to improve function.
Right. Right. Okay. So that's a little reassuring anyway for those parents out there who are worrying about possibly putting their children on medication. I wanted to talk to Scott a little bit about, I spoke to a doctor years ago who told me that there was, and certainly in children, there was no such thing as pure vanilla OCD. And meaning that OCD is often accompanied by many other conditions. Can you tell us a few of the conditions that often accompany OCD, especially in children?
Certainly. The comorbidity issue is important. Certainly.
And comorbidity meaning?
Oh, co-occurring conditions. That is important to consider when evaluating a young person with OCD. Very often, from my perspective, the behavioral treatment involves a lot of tasks that the client is going to have to manage. If there are other conditions also present, these certainly could interfere with the child's ability to complete the tasks which I'll be assigning unless I consider those other conditions and how to work around them. So probably the most frequently co-occurring condition would be tics. About half of the kids receiving treatment for OCD who present for treatment wind up having tics as well. Tics refer to repetitive movements, essentially. They can be rather simple repetitive movements like facial grimacing, eye blinking. They can be vocal, grunts, or words. And they can, in some cases, be rather complex movements, whole body movements that can be pretty debilitating, pretty sometimes even painful for the child. So that's certainly an important one to consider. Sometimes people will mistake a tic for a compulsion. If they see a child doing a repeated movement, people may not always realize that that indeed the repetitive movement might be a tic. What distinguishes a tic is it's the repetitiveness, but also the fact that there's no thought with it. There's no worry. Whereas in OCD, there's a worry that precedes a behavior, and the behavior is done to get rid of anxiety. In tics, no thought and typically not much anxiety.
So it's involuntary, are you saying?
There's some control over it. Very often parents will tell me, you know, he makes it through the whole day at school, but then we'll spend a couple hours frequently ticking after school. Usually it can be controlled to some extent, but ultimately it will express itself eventually. Additionally, though, in addition to tics, I frequently see attentional problems, ADHD, where the child will have a hard time focusing, sitting still. Those are the two major complaints in attention deficit hyperactivity disorder. And that also can complicate the treatment a bit. Certainly, I have to custom tailor my assignments based on the child's attention span and ability to focus. Another co-occurring condition that Dr. Levin mentioned was depression. Certainly, there's the question of the chicken and the egg, which came first, but frequently people with OCD will be depressed.
I can understand that. We only have a few minutes left, and I wanted to say that WJCS doesn't have an OCD specialty or a program per se. What would you advise people, Dr. Levin, who are seeking someone through our clinics to help them with their OCD?
I think first, if the person who's suffering is a child, then of course they need to see a child psychiatrist. And our agency has a number of very capable child psychiatrists who are quite familiar with this condition. But in general, whenever you have a child who might need a thorough evaluation and or medication, you really should be seeing a child psychiatrist and not an adult psychiatrist. In our agency, we have some psychologists who have some skills in this area, but there are centers around the metropolitan area where folks can go to get really specialized treatment at some of the university centers. And there are people in the community who have identified themselves.
And of course, we don't want to forget the OC Foundation, which is available. Their site is the ocfoundation.org, and their telephone number is 203-315-2190. There's a wealth of information there for the layperson. I'd like to thank you both very much for enlightening us today. Stay tuned in our second half. We will be discussing OCD within the family with Dr. Stacy Slater, who is a family therapist in Chappaqua here in Westchester County. Thank you both very much, and I'm sure a lot of viewers are very happy to have tuned in, and you've helped them a great deal.
Thank you.
Bye-bye.
Thank you.
Welcome back to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is in your community when you need us. We are funded by government grants, private individuals, foundations, corporations, UJA Federation, and United Way. Tonight, if you've been watching, you've noticed that we are doing our format a little bit differently. but we are talking about obsessive compulsive disorder in the family. According to the Obsessive Compulsive Foundation, 1 in every 50 adults in the United States suffers with obsessive compulsive disorder. Twice as many have had it at some point in their lives. The condition can start as early as preschool age and can affect people in adulthood and midlife. Families that are affected by a child with OCD often have difficulty finding proper diagnoses and treatment. They also face multiple stresses at home as they try to cope with their child's confusing behavior. In our first segment, Meryl Lewis discussed diagnosis and treatment issues with 2 professionals. Now we will focus on the effect that OCD can have on the family and how parents and children can find support. I'd like to introduce to you Dr. Stacy Slater, who is a cognitive behavioral psychologist in Chappaqua. Thank you for joining us for this half, Stacy. And Meryl Lewis, who was our interviewer in the first half. Meryl is the former chair of the National OCD Foundation and a facilitator of a parent support group through WJCS's Westchester Self-Help Clearinghouse, as well as being our very able coordinator of volunteers and corporate outreach. Dr. Slater, we, in our first half, talked broadly about OCD, but I'd like to review a little and give people a definition. What is obsessive compulsive disorder and how does it manifest itself?
It's an anxiety disorder, and it manifests itself with obsessions, which are irrational fears, and compulsions, which are behaviors that the person does to rid their obsessions. And often a child or an adult is not recognizing that they're doing the compulsion, such as maybe washing their hands, which is the classic, more well-known compulsion, or tapping, but they don't recognize that they are doing it because of a fear. It's just an anxiety that they feel. And then eventually they will know that it's because of a fear that they have, whether somebody's going to die or someone will get sick or something bad will happen.
Mm-hmm. So the behavior itself is not necessarily directly related to the fear. It's not a...
It doesn't have to be.
It doesn't have to be. There are a range of behaviors, and some of them may seem, in our common parlance, people might say, he's obsessive, or she's compulsive about doing things. What is the line at which something that seems so normal becomes abnormal?
Well, first of all, it has to get in the way of functioning. That is the critical piece. And to make the diagnosis of OCD, you really do need both the obsessions and the compulsions. And it gets to a point that they can't get places or do things that they would normally want to accomplish because of these symptoms. So that is how it goes past the more, typical person who's just very obsessive and wants to get their work done or does an excellent job at all their schoolwork. This is how it comes to a place where then it's interfering with doing other things in their life, and it becomes crippling.
At what age might this start exhibiting itself in a child?
Personally, I only see children who are in kindergarten into first grade level, because I do cognitive behavioral treatment and they have to be capable of doing the processing mentally. And prior to that age, treatment can be very difficult. You may see signs in a younger child. For example, you may see if they had a tile floor in the kitchen, you may see they have to walk a certain pattern every time they come into the kitchen. And if you were to ask them about it or try to change it, they would get very distressed. So you may see that in a 4-year-old or a 5-year-old, and it's repetitive. And anytime you try to change that, you'd see this rigidity and anxiety and discomfort in that child. But you wouldn't know that that's OCD.
Right.
It's really the manifestation of several things like that. Maybe at night, bedtime routines, where the child has to have their blanket a very specific way, or make a parent repeat something over and over, or brush their teeth and wash up in such a manner that is so rigid that if you tried to change that, the child would then decompensate. And those would be some of the earlier signs that you could see in a child under, 5 or 6 years old that would make you wonder if this is a child who is going to have OCD.
Okay. When a family begins to recognize some of these behaviors, what types of treatment do you begin with a child so young? What actually starts to work with someone from kindergarten or first grade?
Well, I think the first piece is really education, coming to a professional who is really capable of educating the parent about the illness. That's number one, to make sure that there's that diagnosis, because it could be just anxiety in a child, and it could be their personality, that at times they like routine, and so you really have to clarify that. That's really the first step. And you would start with cognitive behavioral therapy, which is looking at the way the child is thinking and how it affects their behavior when they're at the age to do so. Prior to that, as I mentioned, I would really just work with the parents around it, because they're not capable before about 6 years old, 7 years old, to do any type of cognitive behavioral treatment. There's also medication, which is if there is OCD and the child is very dysfunctional and they cannot respond so quickly to the cognitive behavioral treatments, we'll often recommend to use a medication alongside with the treatment.
When you work with the parents, how do you help the parents to start to organize the child or adapt the environment so that there is less anxiety?
Well, I think the essential piece is that you help them to understand that the child's brain is playing tricks on them, and that is a very essential piece for both the parents and the children, and that if you can help the parent understand that, the child is going to understand that as well. And that to understand it, you need to educate them about how the brain does this, and then how we have to trust that we may feel very anxious and afraid if we don't do these things, or if we throw something away that we shouldn't throw away, or we don't tap 3 times before we go into the next room, that you have to teach them that they must trust that, and then you give them a series of exercises that they can do following that. And everybody has to be on board with this. And I think that when the parents are very compliant, and they are into taking the notes of what needs to happen and doing the homework and the follow-up, it really helps the child to be able to be successful with their treatment.
Okay, well, let's bring Marilyn to this, because as a parent of a child who had OCD, you've had direct experience. And when was it that you actually realized that your son had obsessive compulsive disorder?
We actually received a diagnosis when he was 11. However, we spent quite a few months before that. We were actually in therapy, in family therapy, and the therapist did not diagnose OCD, even though my son was showing quite typical behaviors of OCD. Looking back, he probably had OCD for a very long time, and we just thought they were eccentricities, idiosyncrasies. He had lots of tics, different kinds of vocal tics. He was very rigid in many things. A lot of his clothes didn't feel comfortable, and we just thought it was a behavioral thing, or that he was precocious. We just never had even heard of OCD, really, and especially in children. And then he sort of decompensated in 4th grade and started to do the hand washing. And
so at that point, you began to seek treatment, seek a diagnosis?
yes, we did. We got a diagnosis. Unfortunately, it was 13 years ago, was very, very early on in the field of OCD. And there were almost no people doing cognitive behavioral therapy. Medication was very limited to anafranil, which was an old medication. And we did not have great success, unfortunately, in those years. If he had been diagnosed today, there's a lot more hope.
What is it like to live in a family where one of the members is affected by OCD?
It's unbelievable. You're really a hostage in the family, because the person who has OCD really takes over the house, and his or her needs just take over the house, and you, in the name of peace, you comply, because otherwise it's intolerable. So, for example, my son needed constant reassurance. He had a thing with, was he going to turn into a bad boy? Because he had some trouble in 1 grade, and he said, am I going to turn into a bad boy if I touch this or if I do this? And we used to take a drive upstate to our country house, which was about 2 hours north of Westchester. And he would be in the back of the car, and he would ask maybe 400 times, am I going to turn into a bad boy? I just saw an orange car. Orange is an unlucky color. No, you're not going to turn into a bad boy. And 10 seconds later, it's almost like an addiction, where you just have to keep feeding it. And the more you feed it, the worse it gets. So the reassurance seeking was absolutely intolerable, and it got to be where he couldn't sit at the table unless we covered the table, because he couldn't put his hands on the table for whatever reason. He couldn't walk on his carpet in his bedroom. We had to lay a sheet down so he could get to his bed. Then he started decomposing in school. He couldn't write certain numbers because they were unlucky numbers. He couldn't write certain letters. And finally, we had to take him out of school.
How common are some of the things that Meryl is talking about? Is this the type of behavior that tends to be exhibited? And how do you feel that parents cope with these kinds of situations in their home?
Very common, what she just described, although there's quite an array. It can be, from something minor to something extreme. So there are many, many more types of compulsions that children and adults with OCD exhibit. I think it's very difficult when, a parent is in this position. And I think you're right that you feel imprisoned. And siblings, we have to mention that. I don't know if you had, really, I think, pay the biggest price, because they're children.
Right.
And they're not getting the attention that they deserve. And because it's really being, centered around the child who has OCD.
It's demanding all the attention, and when all hell would break loose, my daughter would be immediately sent to her room and told to lock the door. So she spent, several years in her room, unfortunately.
How about when a child goes to school? I mean, it's one thing to adapt your home and try to make it more comfortable, or adapt the routine of your family, and to recognize that you're going to have to be repetitive and do this. But in school, they are less likely to accommodate all those types of needs. What happens when a child with these kinds of anxieties and disorder gets to school?
Well, I think that you have to get a child designated when they have OCD, because there are special services where they can have an aid in the classroom. So if they have issues with writing, which is what you mentioned with your son, you know, they can use different equipment now so that they can not have to do as much writing, or they can have an aide do the writing for them. So there are a lot of allowances that can be made in the classroom, and teachers, I think, over the past, you know, 5 or 6 years have done tremendous, you know, leaps and strides with making accommodations for children in terms of having the aides there for them to help them with the anxiety and not ostracize the child, because otherwise they would feel very ostracized with their anxiety and having to do all these things. And this is someone who, when they see the child getting agitated or needing to do something or take a break, they can pull the child aside or out of the class to have a little more privacy. So it's very much, I think, a part of the school system today and their understanding of OCD. If they, when they, you know, a psychologist is involved, and the counselors and an aide, and I think it's very helpful.
Meryl, what was you said you had to eventually take your son out of school. What was your experience with the school system and with the ability of a school to adapt to his needs?
I think that it was early in the game in the field of OCD. So perhaps if it was today, I would be much more forthright with what we were going through. Instead, we were very secretive, and we felt there was a stigma attached. We didn't want to have it known that he had OCD because it's a mental illness, and we told all sorts of lies, which really helped no one, and put a tremendous pressure on my daughter, who went to school, and we lived like that for a few years. I think it's always a problem, and I know as the facilitator of the support group, we discuss this all the time, whether to tell the schools, who to tell. Do you tell your mother-in-law, who comes from Chicago once a year on Thanksgiving, why your son does some odd things? Do you tell the teacher? Do you tell the school psychologist? What if everyone finds out? You know, we still have a really long way to go to combat. There is still stigma out there, without a doubt. Will somebody not want your child to play with their child because he does weird things? I think it's a really personal decision about how much you tell and who you tell. But I always encourage the parents in my group not to do what I did, which was to kind of hide my head, and it really didn't help anyone. I like to think, I tell the parents to educate the schools. I give them brochures. I tell them to go to the school nurse, to the school psychologist, to the social worker, and to the classroom teacher. And if necessary, to have the principal call some sort of a meeting so that everyone can understand what OCD is and what the teachers can do to help kids with OCD so that they are not socially isolated.
Can I just touch upon that?
Sure.
That I encourage the children that I see to tell their peers when a peer would ask a question, why did you just do that? Or what was that? Why were you just, you know, making that funny expression on your face? Or you just tapping on the floor. I actually tell them that if it's their friend, and this is someone who's a valuable relationship to you, it's okay to say, sometimes I have this little nervous habit that I do that. They don't have to educate and say, oh, I've got OCD, and this is, but I've got this little, you know, I get anxious sometimes, and sometimes I do these things. And then it doesn't become such a weird thing anymore. And I actually, I find it's, the children feel so much better about themselves when they can be open and honest about it in that way. Secondly, I also have found that some of the children have actually, you know, if they're doing a report or something, they say, oh, I know what OCD is. I have OCD, and they're willing to share. Or, oh, I had that, or I had ADD, and I have found that that is such a more pleasant environment for the children to be in than the more, you know, having more of a stigma. Yes, there'll always be judgmental children and parents, but I think the more we encourage to not be embarrassed or ashamed and to feel good about ourselves, then I think it will show in that the child's confidence. And so I'm a believer in helping them to put it out there in the way that they feel comfortable.
Very often, these children are very intelligent, and this is something that just gets in their way of functioning. But it has it's just one piece of the total picture, I assume.
Right. OCD is not the child, and that's very important to be able to separate. I'm getting very wise as I'm getting older. I wish I was this wise 13 years ago. But it's very important to separate the illness from the child. Because when a child is exhibiting outrageous behavior, and often with kids, it's coupled with maybe oppositional defiant disorder or ADD, and you have these things working and you go crazy and you're flipping out as a mother, but you have to keep reminding yourself that it's not him or her, it's the OCD. And
how likely are young people to outgrow this disorder or be able to adapt themselves so well that it does not interfere with their functioning as they grow older?
I think fairly well. I think today, with both the cognitive behavioral treatment and the medications that we have, I've seen tremendous success. I really have. I've seen children who have been almost completely dysfunctional turn their lives around to be normal, happy, active kids. And yes, they once in a while, especially when they're tired or when they're more stressed, they will exhibit some more of the OCD symptoms, more compulsions or obsessions. But I think prognosis is excellent. And I have seen extremely severe cases and seen really healthy turnarounds. And like I said, we're never looking for perfection. I always tell people there's no such thing. So we're not looking for it to be non-existent. We're looking for you to be functional and healthy and happy. And that is absolutely attainable.
Meryl, as the leader of a support group for parents, you probably are also seeing parents at all stages and of children of all ages. What is the experience as parents get together and share their stories? Are they feeling more hopeful that these can, that through behavioral therapy with medication, their children can attain a normal, quote-unquote, functioning?
I think that in our group, which has been operating about 7 or 8 years, we started about 7 years ago. We have had people in the group with kids as young as 4 and as old as 21. My son is 24 and is functioning beautifully now and has a master's degree, so he has somehow, despite me, done very well for himself. He still does have OCD from time to time, but he seems to manage it quite well. Our group provides support. Nobody knows what it's like unless you live in a family with OCD. And that's the first and foremost piece of the group. The second piece is education and exchange of information. It's so valuable for parents to educate each other. People go to conferences, they read different books, and they do exchange information. People exchange phone numbers, and when they're having an especially bad period, between months, because we meet monthly, someone will call someone and say, hey, can you talk me through this, and could you suggest something? So those are all valuable pieces. I think one of the most important things when people come into the group, we tell them, there are 3 things we tell them. The first is to, if they haven't already done so, to educate themselves. Just know, read everything you can about OCD, so that when you go into therapists, you're going to be an educated consumer. And then we tell them to get support for themselves.
Okay, so there's advice, there's support, there's a comfort in knowing that someone else has been there. We only have 2 more minutes, but how long might a family be in therapy to try to help their child reach a more functional level?
It could vary, but I would say 6 months to a year for sure, and then after that, support. But active treatment, I would say, would be 6 months to a year.
So someone may come in for therapy and then move on to just be in touch with others, keep in touch with you, and find a way to manage their environment and their child's environment.
Well, I think if I could say they use their tools that you've given them, and then if they just have questions, they call back or use the support, but they've been given something, and that's the important piece about cognitive behavioral treatment, is they're not just talking about the issues, they're actually learning strategies to cope with it.
Okay. Do you want to give a little bit of information about your practice? I know you've been generous in sharing your time with us. You can let people know how to contact you if you'd like.
They can contact me at my phone number, is that what you're...
If you'd like, yeah.
At 238-6883.
Okay.
And that's in Chappaqua.
Okay. And Meryl, you had given the information about the OCD Foundation. Do you have that number, or should people contact you directly for it?
You can go on the ocfoundation.org website, and you can get lots of information, or you can call me at WJCS. My number is 914-761-0600, extension 222.
Okay, thank you. Well, I hope that if there are families out there who are struggling with this issue, that they'll have gained a little bit of insight tonight about the ways in which they can cope a little bit better. And if they are interested in hearing about our support group, they can give you a call. And for all types of mental health issues, you may contact WJCS at 761-0600. And if you are interested in the Westchester Self-Help Clearinghouse and any support groups for any number of situations or disorders that you may be experiencing, you may call 949-7699, extension 320. Thank you for viewing, and good night.